All right. I think we're officially live, man.
Mike,
what's going on?
Thanks for having me, man. This is fun. It's gonna be cool. What are we gonna do today?
Well, first, I like your shirt.
I know, right? We're twinsies.
That's good. No, man, I'm good. I'm living the quarantine life. What are you doing? What are you up to besides the 10 minutes we talk on the champion stream?
Hey, that's like a half hour. Come on.
That's true.
Yeah, I mean, I'm only working with a couple of clients now in person, just because of the situation. But still doing a bunch. I think, to be honest with you, I'm busier now than ever because everybody's got some downtime. Everybody's working on projects, and I'm like the project manager for like a dozen of them, and like at Champion, and then my educational company, and then the White Sox and Northeastern, like all these different like things. Everybody's doing so much stuff that it's I'm actually busier. So I cannot wait to get back to the real world and stop Zooming with people and stuff like that.
I know. Are you taking any Skillshare classes? We were talking about doing that. Are you taking any?
I just queued up a few. I'm going through a bunch. I'm going to try to go outside what I usually go for. I was going to do some like iPad, Apple Pencil, like art stuff, like illustration stuff.
I was thinking about that too. I want to take a graphic design course.
Yeah, like something like that. Like I still want to get better with like Photoshop and Illustrator and stuff like that. But I'm trying to go outside the box, with those sorts of things. How about you?
Same. I want to try to do, I don't know what program like is their graphic design one, but they have like a liquid graphic design course where it's all computer based for Adobe. So like it's like logo brands and stuff, just like cool art stuff. But I'm the same with you. I like logged in. Of course, it's so hard to be like, oh, I could take a business course. I could take like a this. I could jump on more PT content. I was like, dude, I need to do something not related to work because I'll just sit here and do it all day long.
Yeah, no, absolutely. I get, you know what? If you're listening, Skillshare, which I'm sure you're not, and if you are, I mean, Dave and I, we both have our own membership sites and stuff like that. I got to admit, it's too much. You get too much on there. There's overwhelm. Like you need a better onboarding for me to get me to jump into things.
Yeah, I even just did like the buy popular courses for the ed course. There's like 14 suggested. I was like, I can't do all these, man.
It's way too much, but it's I don't know. I'm gonna find some good ones. I saw some good ones there.
Yeah. All right. Well, game plan of this is the one benefit to having a quarantine is we have a little bit more time on our hands to do, I think, more just like serving people who have a lot of questions, right? We get hundreds and hundreds of questions on the podcast about, different stuff, which is awesome. But I think sometimes we can't really interact with people and kind of go back and forth and talk about specifically their question more than one answer. So I like these live streams because we can kind of get someone on live and chat or like answer a question and have a little bit more depth over it. So you have taught me a ridiculous amount about the shoulder and many other things as well. And so I felt like I want to share the wealth a little bit and get you on so people could ask you their questions versus, yeah. How's your arm feel? Your arm feels great from not having to throw in the clinic probably, right?
Yeah, this one has been, but I've been doing too many golf swings and now this one's bugging me in my backyard.
I know, right? Chipping away. So I think we have a lot of international questions that got submitted, but Caroline is here live, so she's going to pop on real quick and let's bring her on. Dun, 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 dun. Caroline, what's going on?
Hey guys.
Hey Caroline.
Thanks for having me. First of all, I just want to say thank you so much just for all that you guys do, putting so many resources out there. I'm a student right now, so it's kind of a weird time to be in trying to learn online we're in the shoulder right now, so not having that manual aspect of class has been really difficult. So yeah, I've just been kind of seeking out some other resources, and you guys have so much, so I really appreciate it.
Yeah. Where do you go to school?
I go to the University of North Georgia in Dahlonega, Georgia.
Awesome. I like it.
Yeah.
Great. What can we help you with?
But so my question, I was looking into some of your articles about the posterior capsule and how it seems it's unlikely to see that a tight posterior capsule in the athletic population and more common in maybe post-surgical frozen shoulder type cases. But I was just wondering, out of your experience, what exactly, like how often do you see a true posterior capsule tightness issue, and that you actually need to work on, not using the sleeper stretch.
Sure. Well, I mean, the first thing to consider is in a lot of our athletic patient populations, especially things like gymnastics, we have quite a few hypermobile patients or clients, right? Like they have joint hypermobility. Right. So I think what happened was about 20 years ago, we took like a very simplistic approach of saying, like, if somebody lost shoulder internal rotation range of motion, it must be the posterior capsule is tight, and not that there could be anything else that could be going on. And I think if you really think about it, and if you look at a gymnast, I could almost guarantee that I could dislocate all of them posteriorly, even the healthy ones, right? The ones that don't have any pain, that I can sublux them posteriorly, no problem. So, I think just in general that a lot of athletes, especially gymnasts, have hypermobility of their joints to begin with. But then when you actually start looking at posterior capsules specifically, if you actually dissect it and you go into cadaver lab, which maybe you can do in school, and you look at the posterior capsule, it's pretty thin. It's not a thick capsule like the front of the shoulder is. There's not a lot of stress on it. It almost looks like a piece of like tissue paper, So back in the day, we actually did this in the lab, and we like shined like a light through it, so you could see like it was like translucent, like you could see light going through it. So it can't be that thick. So to me, it seems really unlikely that structure is what gets tight. So, we try to tell people is try to figure out maybe why they don't have internal rotation, and if it's even pathological, because some people have other reasons why they have that, like bony adaptations of the humerus that may just make it seem like it's a loss of internal rotation, but it's really not. That makes sense?
Yeah.
And I can kind of say when I was going through that too, when I first started at Champion, I was still using the sleeper stretch a lot, even though I'd studied it. Like I thought it was the thing to do. And there's definitely probably more effective and safer ways to maybe go about that. How you navigate that with a surgeon gets a little bit different, because sometimes they really want them to do that, but it's a little bit more of a softer skill you got to learn there to get around that. Cross-body adduction and stuff that Mike's taught me with manual therapy is equally as effective, if not more. I think, and some papers support that.
Yeah, I mean, there's papers that show horizontal. There's two papers that show horizontal adduction restores internal rotation better than a sleeper stretch. So so one, that tells you why do a sleeper stretch and torque it. But two, it also shows you that it's that's not working on internal rotation. So why is it getting better? It's probably working on some of the soft tissue posteriorly. So you could still argue that maybe that's capsular at that point, but I don't think it really is. I think it's soft tissue in terms of like muscular restrictions that happen. And then the other thing you can do is you assess, you treat the posterior soft tissue, like the muscles, with like some manual therapy, and then you reassess, and all of a sudden you have your range of motion back. If you had true capsular tightness, I mean, that's, there's some plasticity of the tissue and everything like that, but that's going to take years of modulation to be able to get that to actually lengthen capsular fibers. So I'm pretty sure that's not the case, but yeah. So, I mean, lots of lessons to draw from this, right? I mean, I think one of the big lessons to draw from this is don't assume, right? Always assess, and don't just say like, well, if it's internal rotation, it must be posterior capsule. Like, you have to find an internal rotation loss and a posterior translation loss, right, for that to add up. So, so I think that's the big thing, is like always assess and try to figure out that there might be something else that could be like causing that loss of motion.
Right. Thank you so much. I appreciate it.
All right, cool. Have a great day. Stay safe in the.
Thanks. You too.
That was a good one, right? Look at you, man. You're just like. All right, let me check here. It's funny because I think one of her friends from school said "Go Carol" as she was announcing. That was awesome.
I like it.
All right, let's hop to the next one here. This one is from Charlie. He's in Australia, and he couldn't make the live stream, so he wanted me to ask this to you live. So, what is the best way to treat frozen shoulder from an exercise perspective? How much pain do you get through, or like what's the comfortable range of pain? Because I think he was telling me that he has. Like the person also has a partial supraspinatus tear, so anything above 90 is not so comfortable. And he's wondering like what's the capsular restriction he should maybe push a little bit versus what's like we should ease back a little bit.
Yeah, so hearing that somebody with adhesive capsulitis is having some pain past 90 degrees isn't necessarily surprising, right? I think that'd be something we'd assume, and it also makes sense that he has some partial tearing of that supraspinatus. Because think about it, that inferior capsule is tight, which is what he's having. He's getting a lot of superior humeral head translation. So when the shoulder elevates, it can't go down to get that motion, so it hits that and then just jams up. And then you kind of hit that supraspinatus. So yes, biomechanics still matter, right? That's a good example of that one right there. So you're causing acute traumatic stress to that supraspinatus tendon. So that to me makes all sense. So I think what you got to do is you got to work below 90 and get that capsule kind of loose a little bit. But to answer your question, in terms of like working through pain and what do you do? That's one of those situations where sometimes working through pain can be a little bit worse, right? So with adhesive capsulitis, we go more by probably their end feel and like the sensation that we get when we're doing their activities than we do from pain necessarily. So for example, like when we're doing range of motion or flexibility or even joint mobilizations, if you're doing some manual techniques with your therapist, we want to get to the point where we have like a good capsular end feel and we feel like we're getting something out of it. If they start to spasm or guard against it there, then oftentimes we can have this bounce back effect and then they could actually lose more motion. So we see people pushing it a little bit too far. So a couple of things. I'd say you don't want to push that much. You probably don't want pain, because if you have pain, what you're probably doing is some tissue damage from that lack of mobility. So I'd take a giant step back, work on their mobility within their comfortable range, and then just work on their strength and their fitness exercises within that range as well. You don't want to just like jam it into that as they're healing and going through that process.
Yeah, no, that makes total sense. And I think something else I've learned from just like the research, but also seeing you guys treat, is this is definitely a time when you have to rethink your timelines and rethink your long-term goals, right? Because if you have somebody with like a acute, shoulder injury, you're expecting like within 4 to 6 weeks, if you work it, you probably get some pretty motion gains, versus in a frozen shoulder, the literature is like this is up to like months to years we're looking at in someone who goes through all the phases of their thawing and things like that. So if that's the case, you might not be pushing such an aggressive timeline on someone to like have to get their motion back. It might just come back partially naturally as it comes down, right?
Yeah, and I think what we tend to focus on more than anything else with the treatment strategy with that is probably more of a focus on frequency versus intensity, right? If it was as simple as just like, well, push harder and it'll get better, then everybody would get over it really fast, right? So you have to be able to neuromodulate that a little bit and slowly get that body to respond to it. And that usually requires less load and more frequency. So throughout the day, I mean, if you have adhesive capsulitis or something like that, and you're just doing, like your physical therapy or your mobility stuff like 2-3 times a week, it's probably not going to help that much. Probably need to do it like 4 times a day, right? But I'd rather you do like little micro sessions for 5-10 minutes to kind of tell the tissue again, hey, this is how I want you to respond. This is how I want you to respond. If you jam it and you get pain and you get inflammation, then you're going to have a bounce back effect and probably start over.
Yep. Yeah. Super well said. I think that's a good thing to think about, is the consistency over intensity. I think that goes for a lot of things more in PT, but this is definitely a situation where people got to calm down a little bit and just like be prepared for the long. Sweet. Good one. All right. I just want to shout out real quick, Nick, former PT student. What's up, fellas? Nick, what's going on, man? Good to see you. All right, so let's jump onto this one. So this one actually came in separately, but it's ironically very close to what we were just talking about. So what are your personal experiences on rehabbing pasta lesions, and can you give specific advice? So can you first explain what a pasta lesion is, and then we can say how that kind of links to what we were just talking about?
Yeah, so I mean, pasta, if you look at the abbreviations here, and I may get it slightly wrong, but it's a partial articular sided rotator cuff tear. So, this happens quite a bit. So if you're thinking like this is your ball and socket joint, right? And this is the humeral head, your rotator cuff comes and attaches like this. So most of the time, it's pulling on the bone this way. Most of the time we have extra articular, I'm looking at myself and I'm getting confused. Most of the time we have some extra articular tearing on the outside of the rotator cuff. But with an articular sided, what happens is it tends to happen on the inside, on this layer. So we see that a lot in people that have like translation issues with their shoulder, and then the rotator cuff that's attached on top just kind of like chafes on the inside against the glenoid a little bit. So we see this a lot with like slap tears, overhead athletes, and gymnasts that may have like hyperlaxity in there. They get some partial articular sided tearing in there. So you know, I mean, I hate to oversimplify it, but I don't know if there is a specific thing we would say a pasta lesion needs, and that's what you focus on. I think what you do is you take a big step back and you just say, well, what do they need? Do they need some baseline strength of their cuff and their scapula, those types of muscles? And then do they need to just focus on their ability to dynamically stabilize that humeral head? And that's probably what it is. And that's probably going to be the same treatment advice we give for most of the shoulders. Is you have a very unstable joint, you have to really work on dynamic stability of that joint, so that way it doesn't have some wear and tear on some of the tissue around the joint.
Gotcha. Yeah, it makes sense for sure. Like a lot of these things are like overlapping treatment approaches and styles, and you make these small little like pivots back and forth based on kind of the nuances of it. But I think that was something I struggled with a lot when I was first treating more complicated surgeries, is I thought there had to be like a different recipe for every single different pathology. And it really isn't that way. You know, when you look at some of the basics of how shoulders get injured, you know, different forces, stuff like that. But you should have your kind of 70% maybe of your treatment is very similar in that same kind of box.
Yeah.
Sweet. Very good. All right. So next one is Chris from the UK. Let's see what he's got here. So Chris says, how do you return to horizontal pressing after anterior stabilization surgery? And I think that he works a lot in rugby, and he says that people have either soft tissue remodeling or like ladder J's, and he's worried and he's having a tough time getting people to like cross body adduction where their mechanism of injury happened, and then obviously some pressing for like pushing and blocking and stuff like that. So I guess again, could you explain a ladder J maybe, and then can you explain maybe what your thoughts on that are?
Yeah, so when you start getting to a ladder J procedure, you're starting to get into the world of you know, for lack of a better word, like salvage repairs, where you're starting to have like a ton of structural damage. So with a ladder J, you have bony damage, and then what you essentially do is you try to reconstruct that, and it becomes non-anatomical at that point. So if your question is specific to ladder J's, then yeah, absolutely. You're going to have some limitations in horizontal mobility because your joint is completely different at this point in time. You have a bony block from your coracoid that essentially is intentionally there to try to block mobility. So yeah, that's going to be tough on that one. But I think if you have a ladder J, and you probably go into the ladder J procedure knowing this, you kind of know that maybe your functional abilities afterwards may be slightly limited. I don't know if you're getting back to rugby after a ladder J. I mean, maybe you are, but I don't know. Maybe you shouldn't be. I don't know the answer to that. It depends on the person. You clearly are having some bony defects at an early age that you should just be careful with, or you're gonna have some potential long-term osteo type damage, right? Not just osteoarthritis, but even some big bony loss. So you got to be careful of that, because once you lose bone, it doesn't come back, right? You know, like you got to take a chunk of your glenoid rim or your humeral head out, and it doesn't come back. So you got to be careful with that. But for somebody with an anterior stabilization procedure, you know, I assume your issue is more of like, how do you get back to horizontal pressing when you're talking about the descent area? Because over here is probably nice and stable, and it's probably easy for them. Posteriorly, that would actually be challenging in this position because they would translate posteriorly. It would feel weird. But to get back to horizontal pressing anteriorly, it really just goes down and based on like the healing constraints of the body with that. And for this, it's going to be soft tissue. So what we're doing with the anterior portion of the shoulder is getting them back into pressing probably somewhere around the 12-week mark after that surgery, and just trying to get them to gradually apply that load. This is going to be easy for me. It's going to be getting to a little bit of that depth. So what we do is we just start with a controlled range of motion, right? So maybe even like if you're doing like a pressing exercise, maybe you'd start on your back on the floor, so that way you couldn't even go past neutral. And then theoretically, there's not a lot of stress on that anterior stabilization procedure. So I think you're okay there. And you kind of start with that procedure, and then you can slowly kind of, progress up after that. But if you're getting back to rugby and you got to like worry about this sort of motions with your arm and it can be dragged behind them, what we do is we take all of our principles and we get them nice and strong here, but then we also try to get them strong with their end range of motion as well, and nice and dynamically stable. So we would do things like our rhythmic stabilizations, our dynamic stability. We would do them in their vulnerable positions. So baseball players, right, we'll do them here, right, like to try to simulate stuff like that. But like somebody like that, we may get them back here and work on their stability and endurance and this range of motion, if that makes sense.
Got you. Crushed it, man. That was very well said. All right, let's see what we got. People, if you guys have comments, by the way, you can also toss them. If you have questions, you can toss them in the comments. We'll try to get to as many as we can here. But let's go for closely related, almost-ish, I guess. So here we go. With young athletes who have overused progressive labral tears or cuff tears or instability, when do you start considering surgery? And I think the question that came through was someone who, you know, what's the line between optimism for like waiting it out and just working hard in conservative care versus being someone who is like not really going to do well long term and probably needs a surgery. And I think I couldn't really read the tone of this, but it seemed like this person was a new grad and is kind of getting swept up in the nothing works for anybody, you only need PT, biomechanics don't matter kind of side of the fence. And so they didn't spell that out. I don't want to put words in their mouth. But that's the vibe I got from my DM. So what do you think?
They're all over Instagram right now. They're on the gram right now, getting some Con Ed in. Yeah. So reading through the question, I think the key that stands out to answer this question is that you said overuse progressive. Yep. Labral tears and cuff tears in young athletes. So first off, there's like lots of oxymorons in the sentence, right? But just like meaning like a young athlete shouldn't be getting a progressive cuff tear. That would be pretty bad, you know. But we'll just talk about like pathology of like the labrum, the capsular tissue, maybe the cuff a little bit here. But you said overuse and progressive. So to start at the beginning and answer the question you didn't ask is what would you do with an acute tear, right? Now, when you have an acute issue with like your labrum or your capsule or something like that, the question comes down, it's almost like a 50-50 debate right now, and the surgeons right now, it comes down to what's most appropriate. Should you have surgery right away, or should you see if you have recurrent instability and then have surgery, right? And there's actually studies coming out that if you have surgery right away, you actually have pretty good outcomes and you don't have recurrent instability down the road. And then you don't potentially have those like 2-3 episodes of instability where you're taking chunks of bone out and then you get to something like the latter J, which we talked about in the last question, right? So that's the acute one. So for you, I think the answer lies into that when we talk about overuse and progressive labral tears is I think you do your best to work around it as long as they're not having recurrent instability, right? So if you take an MRI, a lot of us are going to have some potential pathology on our cuff and our labrum. That doesn't mean we don't have functional stability. It just means we have some pathology on there. So to use baseball as an example, we've done studies. We have about 85% of healthy baseball pitchers have cuff and labral signals on their MRI. So we know that they have that. I think it's just from the nature of the activity of our sports, of baseball, gymnastics, stuff like that, where you have stress on those tissues. So you're going to have some signal on an MRI. That doesn't mean it's pathological enough that you need surgery. It's when do you have functional instability. So they're doing a gymnastics move, they're doing any athletic move, and they're having recurrent instability or some pain, or they feel like their shoulder's sliding in and out. You start to talk about surgery when they're having the recurrent dislocations or subluxations, because you don't want to have all that buildup of damage to the tissue. You don't want to make it worse, and you don't want to have bony defects of the glenoid or the humeral head.
Right. That makes total sense. I think instability always seems to be the one that what should I say, that affects their daily life the most and probably brings symptoms, but also always if it's an athlete, they're affecting their ability to train and stuff like that. So, you know, some pain, as soon as you're like, don't know if your shoulder is going to slide out when you're training and stuff, I think that people
that's a bad sign. If you actually are feeling like you're having some subluxations during just like low level things, and you're probably going to need surgery at that point. And I think what happens is you have to say like, all right, is it, do you want to quit gymnastics or do you want to try to have a surgery? And I think most people would have the surgery, and I think I would agree for that. It's like try to do something there, instead of take away the things you love.
Yeah, for sure. Super well said. All right, let's see what we got next. Let's go with this one. So how do you get people from the cleared, in air quotes, side of a shoulder injury to full athletic participation? For example, throwing, overhead weightlifting, etc. So I feel like this person maybe is stuck in the less pain can do my daily life, but then maybe there's an insurance situation, or they're just maybe at a loss of exercise selection for like the, taking you from an A to an A+, which we might need for like advanced rehab type stuff for sports. So
yeah, I mean, I think being cleared just means that you're cleared to start progressively stressing the body to get ready for a competition. But two things come to play. One is, let's say baseball, you said example throwing, right? Or even doing like an Olympic lift, right? Doing that Olympic lift, like doing a snatch or doing like a pitch off the mound, right? Just because you're cleared and you're structurally sound and past the injury, either post-injury or post-surgery or something, just because you're cleared, that just means you're safe to start progressing there. But you wouldn't just jump in and just do a snatch on your first rep, right? You would work back into it. So I think what you need to do is you just have to understand that cleared means you probably have your baseline mobility, you have your baseline strength, probably some good neuromuscular control in your shoulder. You're cleared to begin that functional activity. Now what you need to do is you need to take down the stress involved in that activity, and you need to break down a gradual progression to get them back. So for throwing, for example, we'd go through an interval throwing program where they start with light catch, and then we manipulate all the variables, right? We increase their volume. We increase what's that?
A return to cartwheel program, as Lenny
yeah, we have a return to somersault programs, a return to tumbling, a return to tumble track program.
Interrupt.
I mean, but you just said we're going to manipulate the volume, we're going to manipulate the frequency, and we're going to manipulate the intensity, right? And those are things we're going to do. So for throwing it, so we're going to get further away, we're going to get more intensity, we're going to do it more often, those types of things. So for you, like you may start with like half cartwheels, and then or maybe quarter cartwheels, then half cartwheels, and then progress to more.
Right now.
I mean, I clearly I don't know enough about gymnastics, but the concept again is that you break down the overall task and you break it down into mini chunks, and then you slowly add that to them.
Yeah, got it. For sure. And I think I forget what we said on a podcast one time, but we said like probably 70% of our system at Champion is pretty much for all people, right? Overlapping, whether you're fitness, whether you're not, whether you're gymnastics, baseball, CrossFit, whatever. Probably 70% of it is kind of like things we all should do and learn. And then 30% of that is like, okay, you go be a powerlifter, you go be a baseball player, you go be a gymnast. And so I think people who are trying to work in a population should have a basic system for the joints and for what they do, but then also they should have, their own application of maybe, where they're going to go past that, phase 2 or phase 3, and they can get someone back to whatever they need.
Right.
Cool. All right. Let's see what we got next. People just joining us. If you have questions, toss them in the comments. We'll go for like 15 more minutes probably. Mike is here. More importantly, how's the Pearl Jam album?
It's nice to have something new to listen to during my home quarantine. It's, I mean, it's not their first few albums, but it's they're talented musicians and putting out some interesting, entertaining music. I don't know. I could probably still put on Even Flow right now, like every day, and be okay with it. But I don't know if I'm going to be listening to these songs too much in the future, but like they're fun to listen to now. And I'm looking forward to seeing them performed live.
I think I was listening to Sam Hunt's new album, and like one of the songs is like the Sam Hunt song that you hate, which is just like him talking over like a very slow beat for like 4 minutes. I was like, man, Mike is going to hate this. It's just like, I know I'd see you around sometime. We'd go back. You know what I mean? And I was like,
again, I mean, what do I always say? Like, I feel like he's just flirting with my wife when he's just like awkward. Thanks, Sam.
Together, you're like, don't get any ideas. Don't cheat on me.
Yeah, exactly.
All right, back to shoulders. Sorry. All right, so let's go with this one next. How do you professionally talk with surgeons about timelines to start PT, exercise selection, or protocols? And I think the other part that wasn't involved in this question is she was saying she wants to be professional and like not step on toes and keep the lines of communication open, but like something she was maybe not agreeing with in terms of like what the research suggests for, like we were saying, sleeper stretch, for example, or not starting PT for a long time. And she doesn't want to be upsetting the surgeon because she wants to keep relationships, but she finds it hard to have that communication line with him. or her.
Yeah, but people ask variations to this one a lot all the time, and I don't know if it's like, it's probably we're both guilty of it, both us and the surgeon's perspective in there. But I think we all have a little overinflation of our own worth. You know what I mean? So like everybody thinks like, well, like, oh, I mean, this is atrocious that he says I can't do this until week 8. I think we should do it week 6, right? Like I mean, it's one of those things, like, you know, that surgeon's probably been doing it that way for 30 years, right? So maybe like have an open mind that, you know, maybe it's been successful for them in the past, or maybe there's a reason. But I'd say the other big thing that a lot of times PTs don't get is that the surgeon knows this person from the inside, right? A lot more than we do. And oftentimes they don't tell you all the information, right? So way back, like in the late 80s, like early 90s, Kevin Wilk and Dr. Andrews kind of got together, and they did this for the first time with rotator cuff repairs. But they didn't come up with a rotator cuff repair protocol. They came up with all these different subtypes, and it started off with 3, and it's grown a little bit. But they had a type 1, 2, 3, right, where essentially you had a small tear, a medium tear, a large tear. But the thing that we don't tell you about that like variation there is that it's not just the size; it's the tissue quality. Some people, maybe they smoke, maybe they're diabetic, maybe they have poor nutritional components or something like that, but their tissue quality is poor, and the surgeon doesn't feel like they got a good fixation, or they didn't get a good repair on the tissue. Then they're going to probably slow them down. And then you just have to take a step back and think about that before you say like, oh, the surgeon's so, you know, like he's so wrong, like he's so conservative. It's like, maybe he knows more than we do. So I think that'd be my first piece of advice, is keep an open mind about that, and just realize that most surgeons will have that perspective because of past experiences, right? So maybe they had some failures in the past, or maybe they didn't have good physical therapy in the past, and they had poor outcomes that they're trying to avoid. So keep that in mind. But to answer your question, so how do you talk with them professionally? I think what you need to do is you need to get on a level with the surgeons that they know you, they like you, and they trust you, and they kind of put those things together, that they know that you're someone that's reliable, because they do their surgery and then they go, the patients go away and they never see him again. So if they just have this like plain vanilla program, that's probably going to be appropriate for most people. But we find this a lot with surgeons all the time, is they'll give the patient the protocol, and then the patient will be like, well, oh, I'm working with Mike at Champion. It's like, oh, then just do whatever Mike says, because we have like a relationship with that physician, right? But if they don't know you, they're going to say, hey, just follow this like bread and butter program. It's better than nothing. And just kind of follow that. So I think to answer your question is, if you don't have a good relationship and you can't talk to them about like something personal, like, hey, how are your kids? Or like, hey, did you catch the Patriots game last weekend, right? If you're not at that level with the physician, going to them and being like, hey, can we talk about what week we start range of motion? They don't want to talk to you, right? So is this a bad answer, by the way? Is this live? But so you get them in their environment, and then oftentimes, as we say, you know, you chip away a little bit and be like, hey man, hey, that last person you sent us, like, that was really considerate. You mind if we creep a little faster? And once their guard's down, they're going to be like, oh yeah, no, you can do that maybe a little bit faster. I think you're okay with that, you know. So a good example, Dr. Andrews. He's like probably the most famous surgeon in the world, right? This guy knows exactly what he's doing. He told a college baseball player like a month or two ago to do a certain thing with throwing, just because that's like his staple, what he tells people, right? He kind of forgot that he was up in Boston and working with us. So he told him what to do, and it was like super conservative. It was like wasn't necessarily what I would do. So I just called him. So I have his phone number, right? So we're at a personal level where I can ask him questions. And I'm just like, hey, Dr. Andrews, you mind if we go a little bit faster with Billy? And he's like, yeah, sure thing, Mikey. You know what I mean? I'm like, of course, like, because we have that personal relationship. So the key to the physicians is to get on a level where they know you, like you, and trust you. And then from there, you can have some intelligent conversations. And you know what? They're going to love it, because now they're going to have better outcomes, and their people are going to love them. And that's what they're looking for. They're looking for good outcomes just as well as we are.
Super well said. Yeah, I think that's a good thing to keep in mind, is it's not only about work. It's not only about patients and stuff like that. Gavin says hello from Australia. He thinks we're brothers. So I don't know. Or maybe we just look.
You look like brothers.
Yeah.
I don't know. How's it work? I don't know.
Maybe it's the shirts.
Hey, let's knuckle. Can we knuckle?
Oh,
we just did something. This is cool.
third wall. It's like the Brady Bunch.
I think I gotta back up a lot.
It'd be funny if you could like reach into my screen, if I could somehow come around my camera.
Let me see. Don't punch me. Don't punch me. Don't punch. Are we bored?
Quarantine. Wheels are falling off.
This is funny.
Let's go back to here, guys. If you have, we're going to stick on for maybe like 10 more minutes or so. We have a bunch of questions here, but if you guys want to hop some in the comments, we'll try to get to them before we have to hop into some other meetings. But let's go with this one. Let's go. All right. Where should new grads start with getting more comfortable with post-op shoulders? It feels very overwhelming day 1 to 7, despite having academic schoolwork. So kind of sounds like they know what a labral repair is. They know what a tenodesis is. They know, on paper what they should be doing, but the actual in-person, big bolstered sling and like person like is super painful, doesn't want to move. And especially if it's a new eval, I can definitely see how that's intimidating. You don't know this person. So that's a good question. I'm curious to hear your thoughts on this one.
Yeah, I think you need to get some reps working with these people because you have to know what they feel like, right? And then your academic background starts to come out during this a little bit. But you're going to start like in your head being like, oh, wow, they're really spastic when I move them in their range of motion, or like, oh, wow, that's an empty end feel. I feel like I can keep going further. But the protocol says to stop at 40 to not put stress on the repair. So I'm going to do that. Right. So, to me, I think it takes reps with feeling that. And then that way you understand what's normal. So I always this is probably a good segment for me to say, I always kind of think like our evolution of like our skill sets, it goes from knowledge to skill, right? To then experience to judgment. And those are the 4. So you start with school, you get a ton of knowledge, right? That's all you did in college. You did so much thinking, so much learning, you had tons of knowledge, right? But you're not an expert yet. You're certainly not that good yet. You have to develop your skills. Then you get your skills. Okay, I know how to do range of motion. I know how to work with a post-operative patient, but you have no experience. Then once you start having experience and you're like, oh, I remember now what these people feel like. Or I remember that, this person got sore when I did this or I did that. Then you can start having judgment down the road and start figuring out. That's how you evolve as you grow. So the answer for you is you probably have your knowledge. You probably have decent skill at this point too. You need experience, and that just means reps. So at this point in time, you need reps with these post-operative people. If you just see one new post-op shoulder like every 2-3 months, then you're probably going to feel uncomfortable with them for a long time. Right. So, a whole nother soapbox to talk about maybe, this is where I go off a little bit here on different tangents here, but like a lot of new grads are looking for like good work-life balance to begin with and stuff like that. And they want to look for one-on-one clinics and people where there isn't high volume and stuff like that. And I will say, like, don't be afraid of being in a high volume situation early on because you get a lot more reps and you actually get more experience there. That may not be how you want to practice the rest of your life, but that's okay. Just like do your best in that environment and figure things out and get some reps. It's not a bad thing. So kind of keep that in mind.
Yeah, super well said. I think we talk about this a lot in the podcast, but I think people miss how much work a lot of us put in as we were younger new grads to just get, like you said, just get reps and just see people. And yeah, for sure. Like, and I know you told a story where you were like, you saw like what, 20 to 30 people a day and you're like, I'm never doing this again. But it's right. that healthy balance of like maybe 10 to 14 per day, you're just constantly doing assessments and constantly getting, like you said, pattern recognition. I think that's what sometimes new grads don't like to latch onto and to do. They kind of run away from that because it's so much work. But you got to see a lot of people to get pattern recognition.
Yeah, and that helped shape me and my skill level and stuff. So, it jumped me to having judgment sooner because I had that experience. If you follow those 4 steps, so yeah, I mean, it's there's a bit of a give and take. So I think to answer your question, it's reps. You need reps. Like I know you know how to do it. Now you have to have some experience with feeling that, so that way you get some confidence.
Gotcha. Yeah, super well said. This is good, man. I like this. This is fun. This is way better than one-on-one. So actually, one came in through Facebook, so let's check this one out here. So Meg Crowley says, what are your considerations when returning to hanging activities?
Okay. So I think the first thing you need to have is you have to make sure you have enough overhead shoulder mobility, right? Because a lot of times people don't have as much as they think, and then you lie them on the table and you kind of check their range of motion, like a little bit more strict with the scapula, and you realize you don't have full range of motion. So that's the first thing. Otherwise, you're going to The reason why hanging bothers a lot of people is that you have your full body weight on the bar kind of jamming you up into overhead elevation. So it's not that hanging is necessarily bad. It's just that you're using it. You can't like deload it a little bit here. So what we usually start with is make sure they have good mobility. Then the second thing we do is make sure you have some decent strength overhead. So before we'll hang, what we'll do is just work on some overhead pressing type motions just to get some strength to the shoulders. But then what we'll probably do is we'll probably try to do like a deloaded body weight version. So either where you take some of your body weight off it, or even just do it with like bands and like a tall kneel position to kind of simulate that a little bit at the beginning, gain some confidence, and then slowly work up. But in all honesty, I'm going to defer to Dave. But I was pointing behind me. You're not back there. You're there. But I defer to Dave on what he would do.
Yeah, for sure. And this is actually a good combination of stuff that I thought of kind of, I had my head wrapped around a little bit from the gymnastics world, but then also I learned some stuff from taking some of your courses when I was just out as a new grad. I think that what you said is super important, like full overhead strength. And you have to have a baseline of cuff strength to tolerate, more than your regular daily activities. So, it's hard to kind of expose yourself to that, but you should be doing a ton of grunt work before you even have the conversation about hanging, right? Like sideline dumbbell ER and prone Ys, prone Ts, things that are unfortunately sometimes I think poo-pooed a little bit in the modern world of like, anti-isolation, but some isolated cuff training is going to get you strong enough to do that. And then, like you said, some exposure to hanging is really good. And something that Dan and I built with one of our other programs is like, we try to, and I never asked you, Mike, if we feel the same way, but I feel like someone should always have about 90% of a strength symmetry index side to side on a single arm before they're exposed to any bilateral hang or bilateral compression, because, you don't want to be hanging on one shoulder that can take it and one that can't. So I remember when I found it sometime, but I think doing like half kneeling landmine presses is good, but the opposite is super important is like a banded pull down with like an eccentric elongation, because it starts to put traction forces through the cuff in a way that it hasn't really handled before. So some of my friends do that manually with like, they'll have the person on the table and they'll just gently do some distraction moves and like have the person kind of tug into it. And like, maybe that'll help too. But I find the half kneeling band eccentric is usually a good, if you can tolerate that in an angled range of motion where you're not going super overhead, you can then go under the bar and kind of go an eccentric overhead that way. And then you can kind of progress up to the box. So that would be my 2 cents, but I agree with everything that you said. Sweet. There we go. Teamwork makes the dream work, man. All right. Get back in. Let's take a couple more and then we're going to call it, because we got to get on with our quarantine lives. But I think we have a couple. So let's go with this one. Actually is very closely related to what we just talked about. So let's go here. So not a shoulder rehab question, but I'm curious what Mike did to get so good at shoulders early in his career. Research, courses, books, all question marks.
Yeah, I mean, probably a little bit of everything, right? So, to get good at anything, I think again, takes those 4 steps we talked about. And the big thing there is probably the experience level to get really good at something. And remember that a lot of people are probably better at shoulders than they think they are, or anything than they think they are. They just don't have the confidence because they don't have the experience yet. But then, they end up being fine. So when you're a new grad or even a student, it takes you some time to develop that self-confidence, because you have to go through those experiences to kind of see it. So, yeah. So what did I do to get good at shoulders? Well, I worked with a lot of shoulder patients. So then I kept researching more and more about the shoulder. I mastered the anatomy and biomechanics of it. I did some research on my own, like our own original research. And then we just stayed on top of like learning from the other experts out there. So I think you kind of nailed it a little bit, like research, courses, books. It's immerse yourself in whatever you want to get better at. And what I kind of recommend everybody kind of almost take like a self audit every now and then and say like, all right, what domains of my profession, not PT like pediatrics, neurology, but like ortho. So like shoulder, elbow, knee, back, like what domains am I weak in right now? And if you want to get better in something because you're passionate about it, then go for it. But then you got to also say like, well, what do I work with every day? Because if you never work with ankle patients, right? And you want to get better at ankle patients, you can learn as much as you can. You can enhance your knowledge, right? You can practice skills at a course. But if you never see an ankle patient, it's going to take you a long time to get better at working with ankles. So, you have to put yourself in that environment and completely immerse yourself. And I think that is how you do it more than anything else.
Yeah. And I would agree. I think the other thing that maybe you didn't touch on specifically is that you guys did so much work sitting in on lectures and meetings with the surgeons down in Alabama and just listening to, some of the smartest people around. I think people are quick to want to go to a course in the PT world and buy a new book or whatever, which is awesome. But I think people really undervalue and underappreciate like just giving away your time and just going to these courses or going to these meetings where you can listen to the surgeons talk about, surgical techniques or stuff. And you don't really, does it really matter that we know what type of screws they're using in an anchor repair right now or whatever? It's like not super important, but hearing what the current concepts are and hearing their language and hearing what they think is important is super, super valuable for people to know. Because something I picked up from you guys is you guys worked with like Dr. Kane and Dr. Andrews and everybody else to continuously match up their surgical protocols to your rehab protocols. And then you added your strength conditioning stuff from your expertise. And I found so much value doing that with gymnastics early on because I was stuck in my own little like PT lane. But when I started talking to strength coaches and surgeons and learning from them more, I felt way more comfortable to deal with some of these things because it forced me to really understand the joint fully, not just kind of know what PTs are doing,
Yeah, that's great. That's great.
Cool. All right, let's do two more because I think after that we'll wrap it up. So this one is off of something I said. So let's go with this one. Someone said, going off of Dave's comment, what is the balance of isolated training for the shoulder versus global functional movement training? How do you get it all in a program?
Oof, yeah, absolutely. I agree. Yeah, I mean, you need both, right? So we kind of talk about that quite a bit, that a lot of people want to like poo-poo on like isolated strengthening of like muscle groups and stuff like that and just say we should only work functional movements, right? But, I always say this phrase and kind of teach this way a little bit, but I always say like a weak muscle can't stabilize. So the baseline for us to develop anybody's functional abilities to make sure that they have a good baseline isolated strength. So you have to assess if you have specific limitations in certain muscle groups. So say for the shoulder, like external rotation of shoulder, if that's weak, and then we're just trying to do functional activities like a Turkish get up or something like that, or bottom up kettlebell or anything, you're going to be at a disadvantage, right? So I don't know if I can answer what's the balance, because the balance is whatever the person in front of you needs, right? But we do incorporate both isolated training and functional training into probably everybody's program to an extent. So I would say, yes, do it, but it depends on the person in front of you.
Yep. Cool. I'm going to take this one real quick because I think it's going to be a softball for me.
I love it. Let me see.
This one just came in. What are Mike's go-to con eds that are science-based and practically useful? I'm going to say you should take Mike's shoulder because I took that one. I forget when I took it. When did it first come out, by the way?
A long time ago. We don't need to talk about that. We don't have to talk about how old I am. But yeah, no, a long time ago. I've been teaching shoulder courses for almost 20 years now. So like we've had an online version of it that we've kind of progressed over time online. But yeah, if you just go to MikeReinold.com, you can click on like my courses and see all the ones we have. But I personally love online learning, and I love learning that way. And I think there's a ton you can get out of that online thing. That's your knowledge. Then you just have to practice your skill somewhere. So I would say that. And then, the other big one is, one of my mentors was Kevin Wilk. I mean, he travels around still, and you can catch one of his courses. If you go to a Kevin Wilk course on the shoulder, I think you're going to be really happy.
Yeah, absolutely. I agree. And I think I was lucky to have that perfect balance where that course was online and I could, like, I remember like taking like a week of it and then going to the clinic and just like doing a whole bunch of like the pieces of it with my patients. And it was funny because even people who didn't have shoulder problems, I was like, can I just look at this real quick? They were like, it's my hip. I don't know what you're looking. I'm like, yeah, it's all connected. We just do it without
exactly.
that way. Like,
yeah, absolutely. Yeah, that's how you get reps. We tell our PT students that all the time. Like, if you want to get good at like a Lockman test of the knee, like every lower extremity person you have, just hop up. You're like, hey, Dave, hop up on the table and check it out. How's everything going? Oh, you feeling better? Good. Your hip's doing good? Yeah, good. Let me just check it out real quick. Like bend his knee up and down a little bit, do a quick Lockman, move around. Like, all right, looks good. Let's get into today's session, right? But you just did a Lockman on him. They don't know what the heck you're doing. They're just like, wow, Dave's really cool. He's really looking at me. He's really comprehensive. But you just practiced a Lockman on him. So yeah, that's the way to go. But like,
he looks at everything.
Yeah, I mean, Dave's a man. No, but like in all honesty, I mean, like, so I think if you follow Kevin and I stuff, so myself and Kevin Wilk, I mean, I think you're going to have a good basis of the shoulder from the two of us.
Yeah, for sure. And I would extrapolate that too. Advice to all new grads too is like a lot of people are like overwhelmed by how much there is to learn out of school. And I think in my opinion, every joint kind of has like a handful of people who are really good at, and you should probably learn from them, but then also get like a global system. So like whether, the CPS system that we have is like a good comprehensive system with a bunch of stuff. But if you need specific research on, I don't know, hip micro instability, which is a weird thing I only see, right? Like Mark Safran should be on your PubMed, alerts. You should have all the docs like from HSS, Dr. Kelly and stuff like that. Like their publication should be on your PubMed search review. It's an elbow cartilage thing like Donald Bay and those guys. Like you should find those people who are like publishing research actively to kind of stay up on top of it. That would be my advice.
I think that's great advice too. Is find the people for the specific thing you're interested in and get PubMed alerts and stuff so you can keep up with the latest research. So
yeah.
All
right, let's do one more. Zach says thank you. Zach, you are welcome. Thanks for tuning in. All right, last one here, which might be a little bit of a Pandora's box, so we can end on it now.
Great.
What are your thoughts on youth sport overhead athletes with increasing shoulder elbow injuries? What are we missing the boat on? Oh my Lord, this is a whole episode.
I think it's actually pretty simple. It's just overuse. That's all it is. Over the last probably 30 years, we've tried to blame so many things on why there's more youth injuries. In the 80s, it was the split finger fastball. In the 90s, it was the curveball. In the early 2000s, it was mechanical things like inverted W. Right? That's, everybody's trying to blame it on something. And I think all of those things change the stress that's applied to the body. But it doesn't take away from the simple fact that in every study, the only thing we continue to find that correlates to injury is overuse. Right. So now things like poor mechanics and different pitch types and stuff like that may increase the stress when you're doing your activity, which just means you're more prone to overuse, but it's not that specifically, it's just purely the volume. So I'm part of the problem. So, we can kind of say this, we kind of screwed some things up. I put this on Twitter, I think like a few months ago, and people really liked it. But like we looked at some studies, and if you look at all the studies out there, some of the original research from ASMI, the American Sports Medicine Institute, which is like Dr. Andrews and those guys, what they showed is this one big stat is if you pitch for more than 8 months out of the year, you're 5 times more likely to get hurt. And that's enormous, by the way. Like 5 is not a small number. That's like 500%. Like right now, if the stock market went up 500%, we'd all be very happy, right? Like that's a big number, right? 5 times more likely. And I think you could argue that's why we have so many gymnastics injuries too. And every sport injury is that what we're doing for sports is pushing people to their limits. That's fine. You can do that, but we're doing it too much. So we published that and we started teaching everybody, hey, you can't pitch for more than 8 months out of the year. So now in the winter time, everybody's like, well, what do we do like to train to get ready for the season? Like the research is showing we can't throw bullpens, we can't work on mechanics because then we'd be pitching too much. So people say like, oh, I know. Okay, let's start long tossing. Let's start a weighted ball program. Do these other things. We're like, we're not pitching. Right. But then we found out that long toss and weighted balls were equal to or more stressful than pitching off the mound. And we're the bozos that said you can't pitch for more than 8 months out of the year. But if you're throwing long toss and you're doing weighted balls and you're doing all these other things, it's the same to your body. So I always ask all my athletes this. I say, in the baseball world, this probably makes more sense. But I say like, hey, would you throw like off the mound? Would you pitch 3 times a week? Like all winter? And they're like, no way. I'm like, why not? They're like, that's way too much. I can't throw off the mound 3 times. It's too much. I'm like, okay, great. So you're long tossing and throwing weighted balls and stuff like that. That's more stressful than pitching off the mound. Just remember, your body doesn't care what you're doing. It just cares about the stress. So I think to answer your question, what are we missing the boat on? We're missing the boat on is that our workload has to be prescribed and kids are just simply overdosing.
Well said. All right. There's a lot more questions, but we're going to cut it off. But I have to include this one that just came in just because I know it would your heart. It's simple. Are weighted balls the devil? Somebody asked.
No, I mean, I don't think weighted balls are the devil. They're more stressful. And you just have to manipulate your variables. If you're going to use something more stressful, you have to manipulate your variables. But I would also say that weighted balls aren't angels either. How about that?
Well said. That's a tweet right there. There you go. We just gave you a really good popular tweet.
Please don't tweet that. And then I get all the baseball world will jump on me and get mad.
And the evangelicals, they'll be on your case too.
They'll be very mad.
All right. Well, that wraps it up. A lot of great questions, man. Thanks to everybody that tuned in and helped out. We're going to do another one of these with the one and only Len Mack PT on Friday for knee rehab. So if you guys have knee questions you would like to come on live or ask, you guys can do that. And then do us a favor, just share this with your friends and your squad around the world and people can get more information. So Mike, thanks for your time. And then we will see you. I'll probably see you on Monday on the Zoom meeting for Champion.
Thanks, Dave. Thanks, everybody. Appreciate you guys having me.
Take care.